So I've got 4 cases over the course of the next hour. So imagine for some of these that you're in A&E or in an acute admissions ward. Some you might be in a clinic or in a GP practice. Patient 1 is this young lady, and she is a 20-year-old girl, and you're seeing her in A&E. And she's presenting to you with the complaint of chest pain. So can anybody volunteer some questions that you might be asking her? Any possible diagnoses you might be thinking about? I mean, obviously you go into every case with an open mind, but if you asked every question you could think of for every condition to every patient, you'd never finish taking a history. So you do need to be a little bit focused. And this girl is presenting to you with chest pain. So what are your immediate thoughts and what are your questions going to be? Yeah, you might ask for onset, duration, and severity. Good. So basic questions about chest pain. So she's complaining of severe chest pain that came on pretty quickly. You could ask about family history. But what are we aiming for at the moment? What are your thoughts? What's your differential diagnosis that you're forming in your mind that you're asking her questions to try and work out? The character of the pain, yep, you could certainly be asking. So we could run through the whole of Socrates or whatever you use as your mnemonic to remember all the questions you should ask about chest pain. But what's your differential diagnosis here? Do you think she's having an acute coronary syndrome? Yeah, we could ask, has she got a history of hypertrophic cardiomyopathy? We should certainly ask about drug use in a young patient. So she volunteers when you ask her specifically that she does use cocaine every now and again. Very important in the young patients to try and differentiate the cause of chest pain. But any specific diagnosis you're looking for here, you could ask if it's exertional, but she's had the first onset of chest pain today, and she hasn't tried exerting herself since it came on. Anybody want to throw out a differential diagnosis at this point? Do young patients present with acute coronary syndromes? Yeah, maybe it's pericarditis, maybe it's cocaine-induced coronary artery spasm, good, maybe it's musculoskeletal. She's standing like this for a reason. Uh, it's not just a random picture of a young lady that I decided to put up. Yes, aortic dissection, very good, Arjun. So there are loads of things that she could be presenting with. It could just be anxiety, it could be musculoskeletal, could be GRD, could be loads and loads of different things. But aortic dissection, as soon as you have somebody who has what condition are we wondering about here? As soon as you think they might have Marfan syndrome, that's the number one thing that we ought to be thinking about. So what questions would you ask her immediately to assess could this be aortic dissection? What are the characteristics of aortic dissection chest pain? Yes, where does the pain radiate to? Yeah, so pain, tearing in character, radiating to the back. Excellent. And what other really important question would you ask to help make a history diagnosis for just sticking with the chest pain to make you think that this could be cardiac dissection? So she agrees with you, yes, she's got tearing pain in her chest radiating to her back. Any other question that helps to differentiate it from acute coronary syndrome? So the answer I'm looking for is the speed of onset. So we cause patients to have ischemia all the time in cardiology. We do it when we get them to do stress echoes, where we put their heart under stress. And when you do that, you find that the first thing that happens is that bit of the heart stops moving. before they get pain, before they get ECG changes, that bit of the heart stops moving. And then they start to get the ECG changes, and then they start getting the pain. So with an acute coronary syndrome, you get gradual onset of pain. It fairly rapidly crescendos, but you're talking over a minute or two. With aortic dissection, you get very sudden onset tearing chest pain radiating to the back, assuming your patient has read the textbook. So you want sudden onset tearing pain radiating to the back, which is severe. And generally, you might have some herald symptoms, but you don't generally get previous episodes. Other symptoms that you could ask for, we've covered lots of things about the radiation. We've covered lots of things about the cocaine. You certainly could think about symptoms of breathlessness, but there wouldn't be that much else that you would expect to be going along with this. You would get things like the diaphoresis and sweating that you can get with acute coronary syndrome. Past medical history that we need to ask. Well, we've locked onto the possibility of Marfan's, which is great. We'd want to know about a history of hypertension, particularly uncontrolled hypertension, if we had a patient that was a bit older who smoked. And cocaine use is a big risk factor for acute aortic syndrome. So you get very wild oscillations in the blood pressure with cocaine use, which increase the shear stress and increase the risk of you tearing a flap that turns into the aortic dissection. And it also can predispose to premature coronary atheroma. I've had a 30-year-old who was a heavy cocaine user who had very severe diffuse coronary artery disease caused by the cocaine use. You can also have acute coronary artery spasm caused by cocaine use. So what are you going to look for on examination? Yeah, you do the blood pressure in both arms, and you're looking for a differential blood pressure. So imagine you've got blood pressure that in the left arm is 180/70 and the right arm is 140/50. You might find a pulse deficit. You would listen very good for a diastolic murmur. Excellent. So is this in keeping with aortic dissection? Yes. So I'll come on more to that in just a second. Is there anything else you look for in examination that we haven't mentioned so far to help with the diagnosis of a connective tissue disorder or person at risk of aortic dissection? So you might look at their chest, and what would you be looking for if you looked at this patient's chest? Yes, so skeletal abnormalities. Thanks, Harsha. So can you name them? Yes, pectus excavatum. Excellent. And what's the other one? High arch palate. Yes, absolutely. What's the other chest name that we might be looking for? So it's pectus carinatum. So this is pectus carinatum, a pigeon chest, and this is pectus excavatum, a excavated chest, a chest with a dipping in sternum. Very good. So we also check for spidery fingers, arachnodactyly. We'd look for hypermobile joints. Good. Can you tell me what the name of the scoring system that we use to look for Marfan syndrome is? So we'll come to that in just a second. I'll just flash you up some symptoms and some signs of Marfan syndrome. You've listed lots of them. You have dislocated lens, which I don't think we mentioned, potentially flat feet. So lots and lots of different things we can look for. Can anybody tell me the Baton score? I think I recognize that from somewhere, but I think we use the Ghent criteria for Marfan syndrome. That's the one that I would think to ask my team to try and assess for. So cardiology doesn't usually make the diagnosis of Marfan syndrome, and it would often tend to go via rheumatology, but these patients can present to anyone really, so just be aware to think of those possibilities. So our suspected diagnosis here is of aortic dissection. How do we confirm it's aortic dissection? Yeah, we want to do a CT aortogram. That would be the definitive thing. And before we get as far as a CT aortogram, yeah, bedside echo would be very useful. A chest X-ray, yes. I mean, I wouldn't want to delay getting straight on with the CT aortogram as soon as we hear she's got central chairing chest pain radiating to her back, because we need that in order to know what to do next. But a chest X-ray in a young, slim patient is usually pretty clear as to the diagnosis. We're so used to seeing elderly patients with unfolding of the aorta that you might not immediately think this is a widened mediastinum, but a young person, it should be all encased in that very compact middle segment. All of this here is an expansion of the aorta. So usually you can see a dissection on a chest X-ray, but it certainly doesn't exclude it, and certainly you want to get the CT aortogram straight away. We could do an echocardiogram, which might see a dissection flap. Again, we just really want the CT aortogram as soon as we have a high index of suspicion. What would we particularly look for with the echocardiogram? So the echocardiogram will look at the aortic valve quite nicely, and it will look to see is it regurgitant. If the flap's gone all the way down to the aortic valve and it's causing you significant aortic regurgitation, that's a very big concern, because there's a risk that it bursts at any point, but it shows that it's gone all the way back to the pericardium, and if it bursts into the pericardium, it will cause tamponade. So aortic regurgitation or a pericardial effusion are both very, very ominous findings. So how do we treat a patient with aortic dissection? Yeah, labetalol, excellent. How do you give the labetalol? Yeah, so it's an infusion. And yes, absolutely, we need to know, is it a type A or a type B? So the immediate thing that we want to do is get the blood pressure under control. And labetalol infusion is by far the best way of doing that. A&E doesn't have labetalol, it has esmolol, which is just a beta blocker, as opposed to a labetalol, which is beta and alpha blocking properties. And so if somebody's just taking cocaine, it's better that you give that. But A&E have got esmolol only. You could give an infusion of that. Other ways of emergency controlling blood pressure, you could give IV GTN, but giving IV GTN is generally not advised, because while it will control the blood pressure, it will have a very variable effect minute to minute. So you might have blood pressure control after 5 minutes on a GTN infusion, and then the blood pressure might have plummeted, and it can be quite unpredictable how big a dose will cause that reduction in blood pressure. So giving a GTN infusion means it needs to be very, very closely monitored. And the last thing you want to do is have the blood pressure drop too low too fast and then have to stop the infusion and then it shoot up sky high again. I had a patient who was put on a GTN infusion with aortic dissection who had an arrest because of their blood pressure dropping too low on the GTN infusion, and that was done before I became involved with the patient. The team were doing their best to get urgent control of the blood pressure, and if you're not sure and not able to control blood pressure with other agents, then the most important thing is blood pressure control. But the betalol is a much more controlled way of doing it, providing they don't have acute unstable asthma. So emergency control of the blood pressure. Controlling the pain is also really important. And if you control the blood pressure sufficiently by getting their pain out of the way, which is driving their blood pressure, and by directly treating it, then you stop the dissection flap from extending. So that's essential that you immediately do that. But then we need to be thinking about emergency surgery. And that's defined by where the aortic dissection is. If it starts in the arch of the aorta, then it's a type A dissection. It's a type A and type B, but we just would call it a type A extending down the aorta, and that needs emergency surgery. Type A again needs emergency surgery. Type B arising just after the arch of the aorta, that would mean blood pressure control and close monitoring, and they generally would be managed without surgery depending, or sometimes they can have vascular surgery and have stents put in. We talked earlier about the blood pressure differential. The dissection flap can spiral around, so it doesn't have to be in a specific spot. It can involve the coronary arteries and block the coronaries, or go all the way back and burst into the pericardium and cause a pericardial effusion. So you can present with a STEMI if you have a coronary artery obstructed by the dissection flap, but it could do either coronary artery. It could obstruct your right arm, or it could obstruct your left arm. It could just obstruct one rather than obstructing both. So you get very variable effects, but a blood pressure differential strongly makes you think of it. The main thing is high blood pressure. I wouldn't be saying blood pressure differential helps us or doesn't help us. If we've got high blood pressure and a strong clinical suspicion, we need a CT scan. Good, so that's aortic dissection. So we've just about got over our shock at seeing a 20-year-old with aortic dissection, and we then say hello to patient 2. And imagine you're still continuing your shift in A&E. And this is a 30-year-old gentleman who is complaining of chest pain. And to give you a little bit more history, he was having a surprise birthday party, and it was his birthday party, so he didn't know until he got his nice surprise. And soon afterwards, he felt chest tightness and palpitations. He started sweating and feeling sick. And he's otherwise a fit and well gentleman with no past medical history, medications, or family history. So what do you think could be the diagnosis here? What do you think could be happening? So is everybody trying to think how to spell what they want to write down? Any other questions you want to ask this patient to help you work out what's happening? So the key here is the fact that he's had unexpected stress. Maybe he doesn't like surprises much. Alcohol-induced atrial fibrillation. Yes, maybe he's had too much to drink at his surprise birthday party, but this happened very rapidly after it started. And sudden bursts of adrenaline, either through surprise or through receiving bad news, they can cause Takotsubo cardiomyopathy. So you would obviously want to investigate this gentleman. We might want to take a more thorough history, consider if it was an arrhythmia, consider acute coronary syndrome, and loads of other differentials of chest pain. Maybe he's had a panic attack. But we will want to get an ECG fairly early on. And what do you think of this ECG? So Prinzmetal angina has been suggested, and Prinzmetal angina is due to coronary artery spasm. It wouldn't particularly be brought on by acute stress. It's something which can just happen, and it's a difficult diagnosis to make because it's often quite hard to catch the arteries actually spasming. So that's not particularly the diagnosis that I'm looking for here, but it's not a bad thing to think about. It can be a really tough thing to diagnose, and it's often difficult to treat. So this ECG shows anterior deep T-wave inversion, and you can also see that it's present in the inferior leads, and it's also present in AVR where it's upright rather than negative. And so that might make you think of an LAD syndrome ECG. In fact, there are some rather erudite ways of differentiating Takotsubo from acute coronary syndrome, which I expect you to memorize. The key point here is that while these have got an astonishingly good sensitivity and specificity, specificity at least, according to the person who created these criteria, I do wonder how effective they would be in your hands. And even if you're 95% sure it's not an LAD syndrome ECG, you wouldn't want in a patient with severe chest pain to miss the infarct that's incredibly treatable with coronary angiography. So they're basically going to end up with a coronary angiogram anyway. So the idea of Takotsubo cardiomyopathy is that you have stress that leads to apical ballooning of the heart. It doesn't necessarily affect the apex. It can affect any bit, but classically it's the apex. And it's not well understood how it happens. It's not coronary artery spasm, we don't think, although it's hard to be absolute about that. It often affects more than one coronary artery territory, making it hard to explain with coronary artery spasm. But we think it's something to do with the stress and catecholamine levels causing this transient stunning of the apex of the heart. And it's called Takotsubo cardiomyopathy after the Japanese lobster pots. Takotsubo isn't a totally benign condition by any means. Very often it does seem to recover rapidly, and we do a coronary angiogram, see the classic ballooning features, and then the patients have an echocardiogram a few days later showing recovery of LV systolic function, and they do often then do pretty well. But the risk of patients in hospital having cardiogenic shock, at least in this series of nearly 2,000 patients, was about 10% and about 4 to 5% mortality. And even after getting home and recovering, the long-term follow-up in rates of cardiovascular events and was 10% and mortality over 5% a year. So it's not a benign condition. Tends to affect women more than men. And there usually is an emotional trigger, but or physical trigger, but about a third of patients, or 28.5 to be precise, have no evident trigger. So you don't always have to see an explanation for it. This is only really a very recent diagnosis, because it's only with systems changing so that patients with chest pain go straight to the cath lab to have their arteries unblocked that we actually discovered this condition. If you go back 30 years, it was totally unknown, because they might have presented with this ECG, and by the time we investigated it further, it would have all cleared up and we would have just said that the ruptured plaque healed up. So it's only a very recent, newly discovered condition. Patient 3. So this lady, this time round, imagine you're seeing her in the medical admissions unit, or imagine that you're seeing her in your general practice and she's come to see you because she's developed chest pain. And you ask her your usual Socrates or your usual chest pain questions, and she tells you that it's pleuritic and that it radiates to the back of the shoulder, and there are some positional elements to it. And she tells you that it came on gradually, and it's pretty severe. What are your thoughts about this chest pain? Yes, so this sounds very much like pericarditis, doesn't it? So are there any other questions you might ask to help you confirm your impression this is pericarditis? Any other conditions that you particularly want to consider and rule out? Yeah. So very often these patients have had a viral illness in the weeks beforehand, so certainly ask for that. Anything else? So sticking with the preceding infection idea, pleurisy can have fairly similar sorts of symptoms. So um, you again want to think, could they have had a recent LRTI? Family history. What family history are you thinking of there, Arjun? Okay, familial Mediterranean syndrome. So I would have to accept that I've never looked after somebody with familial Mediterranean syndrome, and while I have dim memories of learning that for PACES, I'd need to go to a textbook to say very much about that. Um, yeah, sorry to disappoint. Any other suggestions? So there are lots and lots of different conditions. I don't know if familial Mediterranean syndrome is one of them, but I dare say it is, since it's been suggested. But lots and lots of different conditions that can cause pericarditis. And so thinking about things like autoimmune or multisystem disorders, things like rheumatoid arthritis can cause pericarditis. You might also think about something like infection. So tuberculosis can cause a pericardial effusion, pericarditis. Um, Rare, but can obviously do it. There are lots of other infections that can. Rheumatic fever can present with pericarditis. So we need to think about lots of different things along those lines. Renal failure is a common cause of pericardial effusion, and you can present with pericarditis again. And there are lots of iatrogenic causes. So have they had a recent cardiac procedure which could have caused it? Or have they had an acute coronary syndrome, Dresl's syndrome, where you develop the pericarditis about a month or so after an acute coronary syndrome? So lots of things to think about there. And medications, again, there are lots of drugs that can cause pericarditis. I would always have to go and look up. Don't carry a list around. But also think about if they're on immunosuppressants that might put patients more at risk of one thing or another. And If a patient has pericarditis and you anticoagulate them, their inflamed pericardium can mean that the anticoagulation that can leak, and you can end up with a hemorrhagic transformation, and you can have an increase in size of your pericardial effusion because of your anticoagulation. That can make the situation worse. So you need to weigh up the risks of anticoagulation against the benefits. I have looked after patients who presented with pericarditis, which has been treated as acute coronary syndrome, and have developed tamponade because they have been anticoagulated with dual antiplatelets and clexane. So just something to be aware of. Don't want you to hold back from giving medications appropriately, but it's obviously important to get the diagnosis right, and that can be very, very challenging at times. So what are you going to look for in examination here? Yes, excellent. A pericardial rub. And what does a pericardial rub sound like? So pericardial rubs can be present when you get patients in different positions. You might hear it just auscultating the chest, but it might be you have to get them on the left-hand side or leaning forwards. They characteristically sound like when you're walking through fresh snow. You know, that sort of slight crunching, slight squeaking that you get when you walk on fresh snow and it compresses under your foot. Not the kind when it's there, it's been on the ground and it's frosted over and it goes crunch. It's more the fresh snow. That's the sort of best description of it. It's sort of an odd sound. And the key thing is to notice that it's not a heart murmur. And it's quite similar to a pleural rub. It sounds quite similar, but obviously is related to inspiration rather than due to the cardiac cycle. So pericardial rub may be present or not. If there's a large pericardial effusion, you don't really expect to hear a rub because the heart's very lubricated. It tends to be when there isn't a big pericardial effusion. Now, imagine this lady was breathless and had been feeling really unwell in the last 24 hours since her chest pain started. And imagine she was anticoagulated. What else would you look for on examination? Yeah, dull heart sounds good. Dull or muffled heart sounds excellent. Anything else? A raised JVP, good, good. So JVP goes up in, so we're thinking of tamponade here, aren't we? So muffled heart sounds very good. Thanks, Snakeham. So features of tamponade, Beck's triad, excellent. So we've got muffled heart sounds and raised JVP, and any other thing that goes with Beck's triad. So what's the other component of Beck's triad? Hypotension, very good. So good. Anything else that we can look for? Any other signs of tamponade? So Beck's triad is a useful way of remembering it, but is there anything else that we should be looking for that really helps us decide if this might be tamponade? I mean, there's at least one other thing that Beck's really should be disappointed in themselves for not adding to their triad and making it, I don't know what the word is for four things, quadrad. Doesn't have quite such a ring to it, does it? So what's the other really important sign that a patient is unwell and in tamponade? Pulsus paradoxus is a subtle sign. So that's, you can check the blood pressure and you can find that on inspiration, the blood pressure drops. Now, actually, normally on inspiration, the blood pressure drops slightly, but it's a increased natural physiology, exaggeration of the natural physiology. So your blood pressure drops by 10 millimeters of blood pressure or more. You can just feel the pulse and get them to take a deep breath in and feel it getting slightly fainter in some cases. So that is certainly a sign of tamponade, but there's something else which you expect from a patient. So we're after tachycardia. So a patient, if they're not tachycardic, you have to ask why. Maybe they're on a big dose of beta blocker, but if they've got tamponade, you're looking, are they tachycardic? Are they hypotensive? Do they have muffled heart sounds? And maybe you get to see your first JVP. Also think about cool peripheries and signs of cardiogenic shock. If patients are getting clammy and cool peripheries, that would also be a sign they're not perfusing themselves properly. Good. So we examine them for evidence of tamponade, and then we start to think, what tests are we going to do on this patient? So what tests would you like to do to investigate somebody with pericarditis, suspected pericarditis? Yeah, we'd like to do an echocardiogram. Before we get as far as an echocardiogram, we might do an ECG. Can you tell me what we might see on an ECG? Yes, saddle-shaped ST elevation. Very good. That's the sort of characteristic one. And you may also get some PR depression. I'll come to the ECG in a moment. So we also want to do a chest X-ray, look for signs of a recent chest infection. Often you can get pericarditis as a result of having a chest infection, just as you get pleurisy as a result of a chest infection. You will want to do an echocardiogram to look to see if there's a pericardial effusion. Typically, with pericarditis, you don't see more than a sliver of pericardial fluid. And if you don't, that's a reassuring sign that you can let the patient go home. If you've got a big pericardial effusion with it, you obviously are going to want to keep them and monitor that. Troponin is important because they could have a myopericarditis. They could have inflammation of the heart muscle as well as the pericardium, and then that's a whole different ball game. So troponin's important and should be normal. And we want to see evidence of inflammation, so raised FBC and raised white cell count or raised CRP. Don't always see that, and it's often not that straightforward to say if it's definitely pericarditis or not. And obviously check other things like the renal function as causes. So if we come on to the ECG, you get a series of different stages. So you get this first stage where you get this saddle-shaped ST elevation, which it tends to be widespread, although you can get it as being focal. Then, as it goes on, the ST segments tend to start to normalize, and you tend to get the PR segment depression. And here in this example, can you see that the PR segment is slightly down? Only slightly down. It's usually a relatively subtle sign. And then you can get diffuse T-wave inversion, which then usually normalizes, but it can become permanent. So we get lots of different signs depending upon the stage of pericarditis that you're looking at. And I would say that it's very common for the ECG not to show clear-cut evidence of pericarditis. So if everything else in the history is pointing towards pericarditis, you don't have to have ECG changes. So how do we manage it? Well, let's give you a second to answer that question before I give the answer. Let's move on. So we obviously want to do reassure the patient that pericarditis usually is not serious, but it does often recur. Rarely in the long term, you can get a constrictive pericarditis caused by scarring and inflammation from the recurrent pericarditis. So that can be more serious, but for most people, it isn't a too bad a problem, although it's obviously an inconvenience. We can give analgesia with non-steroidals, so a course of ibuprofen. And colchicine has been shown to reduce recurrence. So we would also, you can have second line things like giving low dose corticosteroids to suppress it, but non-steroidal anti-inflammatory drugs and colchicine are the first line treatments. Great, one more patient, almost there. So this time, imagine that you're seeing this patient, a 35-year-old gentleman, and you're seeing him in clinic, non-cardiology clinic, or you're seeing him in your general practice surgery. And the patient is being seen for something completely different. You're seeing them for their ingrowing toenail or their totally non-cardiac issue. And you know that they have got cardiology problems, and they're telling you now that they've got chest pain just as you're about to finish and you're already running late. So the last thing you want is to be told the patient has got chest pain, but you can't not do something about that, can you? Because maybe he's going to go out and have an infarct. And when you go to the inquest, nobody will realize just how busy you were that day, and that won't matter. So what are you going to do to try and work out how to manage this gentleman who's known to have cardiology problems and is now telling you they've got chest pain? Deathly silence. An ECG. Okay. Good luck getting an ECG in your general practice surgery that you now find yourself in. So what questions are you going to ask the patient? I mean, we're going to ask them the usual chest pain questions, aren't we? But what are you looking for? What answers are you looking for? What are the most useful questions to ask the patient? So you have to decide, has this patient had the misfortune to develop an acute coronary syndrome in the last few days or minutes or hours before coming to see you? And they might have done, but the chances of that, if they're coming to see you for something completely different, are fairly low, even if they're a very high risk patient. But they could yet still have done it just to spite you. And it's really important, therefore, that you decide, does this patient need to go to A&E, or can you reassure them about the pain and tell them to carry on and talk to their cardiologist about it next time they see them? So the questions that you're after are things like, is the pain something they've been getting for a long time, or has it recently changed in nature? So if they've been suffering with this pain for the last year and it's no worse now than it's been the last year, then it's not an acute coronary syndrome and you can relax a bit about it. You can ask basic questions to see, could it be cardiac? So is it central? Does it radiate? Do they get short of breath of the pain? Well, if it's cardiac, they will, but very often patients get short of breath with chest pains, whether we think it's angina or not. So that doesn't help you a huge amount. But the exertional question is a good one, because if the patient is, sometimes I see patients complaining of chest pain who are running 5 kilometers in the morning, get some chest pain in the afternoon and think it's cardiac, and have been doing that for the last 2 weeks and come to me and I say, well, you're still running the 5K? Well, then the pain you're getting every afternoon isn't cardiac then, is it? Because you'd be not be able to run the 5K, or you'd be getting the chest pain running the 5K if that was the case. So the fact that it's not related to exertion is helpful. Now, you'll immediately be saying, but unstable angina, patients can get chest pain at rest, and they absolutely can. But typically, if they have unstable angina, they will also be getting exertional angina. So ask about relationship to exertion. This patient's telling us the pain lasts 30 minutes to an hour. Is that useful? Well, the answer to that is it's tremendously helpful, because if it's cardiac chest pain and it's lasting longer than about 15 minutes, we would expect that to be damaging the heart, and we would expect that to result in a troponin release. As soon as it lasts longer than 30 minutes to an hour, that's actually a really helpful thing to tell us that either they've had an infarct or else it's not cardiac. Now, nothing is absolute, but that fact that this is lasting for long periods of time, or if they say it's lasting for hours and hours, lasts most of the day, it doesn't clear up until I wake up in the morning, that's really helpful in telling you it's probably non-cardiac chest pain. So any patient that does this when you're in a non-cardiology setting, it can be really hard. I get these referred to me all the time, and it ties people in knots. But the key things are, is it a new symptom, or has it been going on for a long period of time? Is it related to exertion? And is it lasting for long periods when it comes on? And those features can help you distinguish between pain that you might need to send the patient by ambulance to CCU, or actually things may be fine. You obviously want to know about why they've got the pain. There are all sorts of conditions that could mean that patients get long-standing chest pain. It could be that they've had severe coronary artery disease even at 35, and maybe there are bits that we've unblocked and bits that we can't unblock because they're too small to be fixed. Though in those situations they're often not serious in terms of prognosis, but getting debilitating chest pains can be very bad news. There is a huge amount of emotional overlay with chest pain. So patients who think that they've got a problem will get symptoms, and it's so important to manage both the underlying condition and the patient, and help them have the right perspective of what they've got going on. Patients with hypertrophic cardiomyopathy and with hypertension causing left ventricular hypertrophy can get chest pains related to the hypertrophy. I'll explain that in a minute. That would be a common cause of chest pain that isn't ischemic, and patients with cardiomyopathies not infrequently complain of chest pains, often chronic, of the type that we've just described here. And then things like Prinzmetal angina could potentially be causing these symptoms as well. And here you'd be wondering, is it always spasm which is causing it, or is the emotional component to it causing some of these pains? Also ask about things like family history, and maybe there's a lot of stress the patient's under at the moment, or maybe there's something on their mind, like their father died at a similar age when they were young. So we've got a wide differential diagnosis, as we've just talked about. Prinzmetal angina, vasoplastic angina is the same thing. One thing I didn't mention is if he's got a history of heart failure, often breathlessness due to heart failure can be associated with some chest tightness. So that could be the reason for things being worse. And investigations, well, the best thing you can do, if possible, if it's clear that it's not cardiac, is nothing. You could think about doing an ECG, but that's potentially going to be awkward because it probably isn't going to be normal. And if you don't have an old one for comparison, you might be no further forwards. And if you're satisfied clinically that this is not an acute coronary syndrome, then you don't need to do an ECG. Troponin can be helpful, but often with these conditions, with certainly hypertrophic cardiomyopathy or hypertensive heart disease causing chest pain, the troponin will be chronically elevated. So if you do a troponin, it will be up and you'll have to do another one. And if you're doing a troponin, the patient really needs to be in hospital, because what if it's raised and you've sent the patient home? It it simply isn't a good idea to try and do troponins with the patient at home for chest pain diagnosis. And doing serial troponins or knowing what it normally is can be helpful. If you think it might be heart failure, then an NT-proBNP is very useful. And then there are other tests you can do if you really want to know, is it ischemic heart disease or not? But really, these should be left to the cardiologists, assuming the patient's known to cardiology, of course. So how does hypertrophic cardiomyopathy cause chest pain? So imagine a heart and imagine slicing through it. And imagine how thick the muscle is in somebody with hypertrophic cardiomyopathy. So the blood supply to the heart wraps around it. And as the heart muscle gets thicker, it's harder to push it open. So the diastolic pressure goes up. Higher diastolic pressure means it's harder for the blood to get through. And you can see how bits of the heart might not get their blood supply when the heart becomes very, very thickened and enlarged like this. If a patient has stable coronary artery disease, they do not benefit from intervention. So we know that patients with stable heart disease do just as well with conservative treatment, which means excellent lifestyle, aspirin, statin, and blood pressure control. So excellent management will mean stable coronary artery patients do as well with just medications as they would with coronary angiograms and stenting. That's totally different to a STEMI, where they have a hugely better off if they have primary angioplasty rather than thrombolytics or other treatments. And bear in mind that statins, that the troponins can go up with all sorts of other things. I don't want to go over this list right now. We'll talk about acute coronary syndromes another time. I hope you've been logging in and looking at the YouTube channel, which has got lots and lots of videos on it, some of which are new. This one isn't on there. It's a brand new presentation, some of which I will be giving at some point during your time with us. But if you miss out, they're on there to look up. There's also the Fun with ECGs to look through. Thank you very much for listening.